So you know, basically we are having congenital heart disease. So what is the major group of congenital heart disease? Cyanotic and acyanotic. Another group is when you say heart disease, you will have a acquired or congenital. That is the basic issue. And congenital heart disease itself is having a cyanotic or acyanotic congenital heart disease. Acyanotic congenital heart disease means you will have major group. What are the major group of acyanotic congenital heart disease? PAEDIATRICS, CHD, VSD, coarctation of diaphragm, pulmonary stenosis, all these things, mitral regurgitation. So all these things are congenital heart disease. So we can easy to remember what is this ASD, VSD, PDA. These are shunt deletions. Shunting blood from one chamber to another. ASD is shunting in the atrial direction. VSD is shunting ventricular, and PDA is shunting great artery. Between the two arteries there is a connection. So that is the shunt. And there is very rare, very small, you need not study attitude. It is better to keep the AP window. Aortopulmonary window is also comes in the shunt lesion. So these are the shunt lesion. Where the shunting on this ASD, VSD, left to right or right to left? Left to right. So the shunt can be right to left or left to right. If it is left to right, it will be acyanotic. If it is right to left, cyanotic. So all these shunt lesions what we told is left to right, that is acyanotic. Okay. So what about this obstructive lesion? What we have told is a shunt lesion. The other one is obstructive lesion. Obstructive lesion can be right side or left side. Right side, which side obstruction comes? In the outflow tract, right side, what is the pulmonary valve, pulmonary stenosis. Or if it is going beyond the pulmonary valve, what is there? Pulmonary artery. So it becomes narrow. What do you call that? Pulmonary atresia. Pulmonary atresia. Or pulmonary branch stenosis. So valvular level, vessel level. Similarly, on the left side, what is there? What is the vessel? Aorta. What is the valve? Aortic valve. So aortic stenosis. So these are the basic major congenital heart disease. But what we have to remember is in your examination, which case is likely to keep is pink disease. Which is likely to keep is only two: VSD, PDA. So you should know something about all these things, but very detailed about VSD and PDA. So that is the major case we are taking. The other ASD may not be cut, VSD coarctation may not be cut, but VSD can be cut and PDA can be cut. So that is the major thing. Then what about the other than like pulmonary stenosis, pulmonary atresia, coarctation, and aortic stenosis? These are left sided, right sided, and very rarely we get congenital MR, mitral regurgitation. Valve is deformed and producing congenital MR. So these are the basic left to right shunt. So how we are going to diagnose it? So that is what we have already told. See how we are going and classifying all these things. The shunt itself is a pre-tricuspid shunt and a post-tricuspid. Pre-tricuspid is ASD. Post-tricuspid is ASD, VSD, PDA, PDA. Obstructive stenotic AS square, and right side is pulmonary stenosis, and others are this Al-Kappa and MR, very rare conditions. Okay. So how we are going to diagnose? By taking the history, physical examination, go for investigation, and finally confirm your diagnosis. History, what all this is? You will ask about the symptoms. So what will be there if there is a shunt lesion? What are the symptoms? All cardiovascular cases discusses the major cardinal four cardiovascular symptoms. What are the four cardinal symptoms? Chest pain, palpitation, fatigue, dyspnea. Chest pain, palpitation, fatigue, dyspnea. What is important of these cardinal symptoms? All these four symptoms are classified based on NYHA, or in infants you are using modified Rose classification. So that is how the functional stratification. Not only the chest pain, all these four primary symptoms are classified. That is the one thing. So when you are having a lungs which is perfused more, all these shunt lesions, ASD, more blood is going to the lungs. VSD, more blood is going to the lungs. PDA, more blood is going to the lungs. Then more blood is going to the lung means there is more chance of pulmonary plethora, more chance of pulmonary edema, more chance of orthopnea, more chance of BND, more chance of recurrent respiratory infection. If the child is getting recurrent respiratory infection, cardiac failure, what will happen? They will have failure to thrive. So what it means, when you are having a depression, all these symptoms you are asked in the history. Recurrent cough, recurrent respiratory infection, failure to thrive, PND, orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitation, all these things you have to ask. But on the contrary, if you are having a decreased pulmonary blood flow, there is less blood is flowing, less chance of recurrent respiratory infection. When the severity of flow in the lung is decreased, what will happen? There can be less blood is flowing to the lungs, there can be cyanosis or abrupt intolerance of this kind. So what we are dealing with mainly increased pulmonary blood flow. In the history you have to ask about all these symptoms. So then you know these are the increased pulmonary blood flow. Then another thing is antenatal history. Antenatal history, what you will ask if cardiovascular phase? Preterm. What is the heart disease common in preterm? PD. Because the child will come out early. So they will have chance of persistence of the ductus. And what about the birth weight? When you are having IUGR, what is the commonest cause? Low birth weight. Yesterday we studied microcephaly, cataract, deafness, rubella syndrome, CRS. What is heart disease? PDA. So PDA or pulmonary stenosis can be disease. So you have to ask about the intrauterine infections and preterm maturity and birth weight of the child. Preterm, low birth weight, PDA. IUGR, intrauterine growth restriction. Then PD or pulmonary stenosis. Mother is having gestational diabetes. What is heart disease? VHD can be there. The common heart disease is asymmetric septal hypertrophy. There can be thyroid heart disease also. So you have to ask about the maternal illness, infections, and the gestational age, birth weight of the child, and drugs. Drugs can also produce heart disease. Fetal alcohol, fetal hydrochloride, fetal valproate, all that. So drug intake is also important. So that is about the antenatal history, natal history, and all these things. And age of the parents. Age of the parents. That is more the younger extents of age, more chance of chromosomal anomalies. And what is the commonest chromosomal anomaly I am seeing in the world? Down syndrome. What is the commonest heart disease? Endocardial cushion defect, followed by VSD. So they can have. So you have to know. And if there is consanguinity, there is again chance of chromosomal anomaly. Syndromic babies. Again, you will get more chance of heart disease associated with. Other than Down syndrome, any other syndrome? Turner syndrome. What is the heart disease? Rotation of the left sided obstructive lesion. Rotation of aorta, bicuspid aortic valve. That is common in Turner syndrome. And similar to Turner. What is that? Nuna. Is male. There can be right side obstructions. Pulmonary stenosis, pulmonary branch stenosis. So that is also important. So these are some of the points you have to ask in the history. Then you will go for the. So first you ask whether there is a presentation is with the symptom or without symptoms. Symptoms you already discussed. And when you go for clinical examination, what are the clinical examination? Pulse, BP, JBP, all these things. By pulse examination, out of these shunt lesions, which one you can diagnose? PDA. What is that? High volume collapsing pulse. So you can diagnose any other disease by pulse examination. Coarctation of aorta. There can be radiofemoral delay, weak femorals, that can be there. Any other disease that can be diagnosed by pulse examination? Other than mental disease? What happened in aortic stenosis or hypoplastic left heart? Low volume pulse, RD pulse. Heart failure, low volume pulse, tachycardia, narrow pulse pressure. So pulse is again you can make some diagnosis. And if you take the shunt lesion out of this ASD, VSD, PDA, which is more likely to have no symptoms? ASD is less likely to have symptoms. And the more the bigger size of shunt, VSD and PDA are presenting with more of a symptomatic presentations. So when you ask the patient what is there is no symptom, most likely it is ASD. Or it is a very small shunt. Small PDA, small VSD, all these things can remain asymptomatic. So symptoms based on you can. And if you take the statistics, what is the commonest congenital heart disease? VSD. So isolated ventricular septal defect, it is 35%, 1/3 of your heart disease, congenital heart disease. So if you take an association of VSD, PDA, VSD, PS, that will make around 50% of the ventricle. So if you are getting a murmur, you cannot identify what it is, but you are putting a diagnosis as VSD. You are being on the right side 50% chance. So your task is to find out at least one murmur. That is the thing. So then you can diagnose. So that is the one. So that is about the physical examination. And if you go out of these three shunt lesions, which one is having right ventricle is dominantly volume enlarged? ASD. ASD is having right ventricular enlargement. If there is right ventricle enlargement, will there be any cardiac failure? The VS right ventricle forms the precordium. It is bulging anteriorly. Then there is no chance of getting a cardiac enlargement. And what about the other shunt, VSD, PDA? It is left ventricle is getting enlarged. So you will have a left ventricular type of cardiomyopathy, down and out enlargement. So it's simply you ask about the symptoms, you feel the pulse and look for which chamber is enlarged. If it is right ventricle, more likely it is PS or ASD. And if it is left ventricle, more of a VSD or a PDA. And then if you feel the pulse, VSD, PDA, pulse is there, high volume collapsing, your diagnosis is PDA. Then what is the PDA? It is only VSD. Okay, so now what else? You go on auscultating the child. What is the murmur? VSD, you will get a pansystolic murmur. And in a PDA, it is a continuous murmur. So you are getting a continuous murmur. That means high volume pulse. You look for high volume pulse, then you say it is PDA. And other settings, low birth rate, IUG are more confirmed. So without doing any other investigation, you can make a diagnosis. So that is about the physical examination. Murmur, pansystolic murmur. Depends on the murmur place, you can say VSD is lower left sternal border, it is perimembranous. It is upper second sternal border, it is outflow tract murmur, or subaortic or subpulmonary VSD. And the muscular VSD, it is in the apex, there can be a pansystolic murmur. Then it is apical muscular VSD. So that need not, but at least you say there is a pan-systolic normal. Then you can identify. Then, if it is a continuous normal means the murmur starts from the S1 and crosses of the second axon, occupies the varying intervals of diastolic phase, we call it as continuous. It need not be throughout the diastolic. The peak of the murmur is around the second axon. So that you find it very difficult to identify where is the second axon. So that is the continuous murmur. You can make the diagrams of PD. And what is there in ASD? RV type, no cardiomyopathy. And the classical murmur we are getting in ASD is a ejection systolic murmur in the second left sternal border intercostal space. That is the pulmonary stenosis. That can also present like that. Apart from ASD. So two diagnoses. Second left sternal border ejection systolic murmur, two diagnoses. One is pulmonary stenosis and another one is ASD. And if it is a pan-systolic murmur, then it is subaortic PSD or subpulmonary PSD. So how you differentiate PS from ASD? ASD, the second axon is wide and fixed split. What is there in pulmonary stenosis? Second sound become soft. So it is not well done. So that is the way you can differentiate from ASD and the PS. So that is about the physical examination findings. Finally, we go for take X-ray, ECG and find out confirm the diagnosis. So this is what all we have told about how they can present with cardiac failure, murmur, recurrent respiratory tract infection, failure to track. Patient can present with cardiac failure features. And when you get the stroke and syncope, it is outflow decreased. Why outflow decreased? AS or coordination. They can have headache, hypertension. They can have syncopal attacks and all these things. So these are the features of left-right shunt. We have already told absence of cyanosis because right to left shunt is cyanosis. Left-right shunt is no cyanosis. Recurrent respiratory tract infection. Increased pulmonary blood flow leading to cardiac failure. Patient is getting recurrent infection, failure to track, and there can be precordial bloods. There can be cardiomegaly. There is a shunt murmur, pulmonary plethora, and they will have ECG and the X-ray evidence. So this is how we are going to pick up the diagnosis. This already we have told how you pick up based on the pulse. Then BP. If there is a pulse difference, naturally blood pressure will also vary. So there is coarctation. If the pressure difference between the two limbs, you call it as anisospicmia. That will get in coarctation. Wide pulse pressure you will get in PDA, AR, AP window, all these cases. So that is the BP, how it will help you to identify the heart disease. So hypotension, aortic stenosis, and wide pulse pressure, AP window, PDA. Difference in upper limb, lower limb pulsation is the coordination. Anisospicmia. What is the term we are using? Difference in the pulse? Anisospicmia. This is stigmomanometer, spicmia, blood pressure. Stigmia, it is pulse difference. So JVP is hard for you. And the pre-tract resistance we have already told about ASD, asymptomatic, mitral valve is RV dilation. This is the shunt, and this is the picture of the ASD. What is there? The heart becomes almost a globe because the right ventricle is not dipping down, it is going up. And we are having what is that prominent thing? This one pulse. That is the main pulmonary artery is getting dilated. That is the bulge you are seeing on the left border. So post-tricus shunt, it is all these things we have told, recurrent respiratory infection, CCF, murmur, clearly chance of pulmonary hypertension because increased blood flow, pulmonary hypertension. Polyovular left atrium, left ventricle is getting enlarged. Okay, these are the increased pulmonary blood flow. It produces pulmonary congestion, interstitial edema, recurrent infections, and chest growing because there is pulmonary edema. Your alveoli are not expanding. You put extra muscle effort. Patient will get a work of breathing increase. As the diaphragm is going on contracting, you will get a narrow circle around the attachment of the diaphragm. What do you call that? Harrison surface. Harrison surface. And then there can be precordial pulse, precordial activity. It is fastly contracting and forcefully contracting. Why there is forceful contraction? Because there is volume of load, there is forceful contraction. What is that law? It is the Frank-Starling law. Frank-Starling law. Initial length of fiber is more the force of contraction. So when you are having volume overload, the muscles are stretched, more forcefully is the contraction. So that is the Frank-Starling law. Who is that? Name that person who told the answer. It is Kannagi. Okay. Then, because if those who are answering maximum number of questions will sweet gift is waiting for you.
Even one answer will give.
Yeah. Even one answer. So now this is what I have told about the different types of VSD. Depends on the position. Imagine they are still looking from the left ventricle is here, right ventricle is from the other side. So you are seeing the left ventricular side of the intraventricular circle. This one, full area. This part there is the inflow of blood. Blood is coming to the chamber. See, this side it is left ventricle, other side it is right ventricle. You are seeing the septum. And this part of the septum, the AV valves. Right side tricuspid valve, mitral valve on the left side. So the part of the septum which separates that AV valve is the inflow. Blood is coming inside the ventricle. The part of the septum that separates the outflow, that is between the root of diaphragm and pulmonary artery. It is outflow tract. So what is there? Inflow. There is a defective called inlet VSD. Inlet VSD. And when you are having an outflow tract, it is outlet VSD. Or what you might have studied in your anatomy, that is crista supraventricularis. That is the area where the rough right ventricle, there is a band muscular layers. Above that is the outflow area. So it is called supracristal VSD. Supracristal VSD or outflow VSD. So you are having an inflow VSD and outflow. And between the inflow and outflow there is a narrow area. That is membranous part. So you call it as membranous VSD. And membranous part is very small. So it is very rarely you get a VSD involving only the membranous cell. It will involve the adjacent area also. That is why it is very membranous. And which is the commonest type of VSD? Very membranous. What is your name? Tell your name. So perimembranous VSD. And what is there? This part of the ventricular septum is muscular septum. If you go anteriorly, that is towards the right ventricle, you will anterior muscular VSD. If it is going posteriorly, it is posterior muscular VSD. Muscular VSD, epic and anterior posterior. And inlet VSD, outlet VSD, and perimembranous VSD. And the perimembranous is most common. Why we have to study this one is the location of the murmur will change depends on, as I told, outflow tract is upper sternum, perimembranous lower left sternum, muscular it is the apex. So then you can say very clearly, sir, it is muscular, we affect muscular. So in apex there is a pansystolic murmur. What is the other differential diagnosis? Who is that? Yes, tell your name. It is the mitral valve. Mitral valve regurgitation produces a pansystolic murmur. Then how we are going to differentiate apical muscular VSD from mitral regurgitation? How you differentiate? Apical muscular VSD and mitral regurgitation. How we are going to differentiate? Yes, you. What is your name? So apical muscular MR connected to the axilla, and muscular VSD the murmur is well localized. So that is how we differentiate. So these are the differential. And when you are writing the VSD diagnosis, you have to say whether it is a small VSD or a large VSD, like that. So how you are going to identify? When you are having a ventricular septal defect, small one, the difference between the right and left ventricular pressure is large because the defect is small. So through the small hole, blood is rushing. What will produce? A rough murmur, harsh murmur, and it will be there throughout the period of systole. So then it is called pansystolic murmur. So a rough pansystolic murmur, entire part of the systole, it is a small VSD. Suppose you are having a very large VSD, what will happen? The murmur is not going up to the entire period of systole. Why? Because the right side pressure is also increased because of the pulmonary arterial hypertension. So the murmur restricted to the early part of the systole, not the entire. So what you can find out is, see, the first one, the murmur starts from S1, ends in the H2. So you will listen, there is a so there, the first sound is immersed in the murmur, and the second sound you can hear at the end of it. So most of the students, they will come and say, I can hear only one sound.
Who can imitate that?
No one can.
No one can. Huh? Who will try? Who is Sherry?
So that is the way you can, because when even before the systole starts, the left ventricular pressure is confronting your systolic pressure, and the right ventricular pressure is only 20 or 18 millimeters. The other one is 80, 120. So even before the ventricle contracts, there is a pressure difference. The blood starts flowing, and the blood starts flowing means it will produce a turbulence. It will produce a murmur. Afterwards, only the AV valve closes. So the AV valve closure will drown inside the murmur. So you cannot write out the S one. What you are hearing is at the end of the murmur there is a sound. So that is the S. So that is the pansystolic. But when the pressure in the right side is increased, the restriction of flow even before the completion of the systole. So then it restricts towards the early part of the systole. So that is the large VSD. So if there is a large VSD, if there is pulmonary hypertension, what finding you will get? Loud P2. Loud P2. And what else you will get? Right ventricle is getting enlarged. So you will get a LPS. Moreover that, the right ventricle, there is epigastric pulsations. So epigastric pulsations, left parasternal hip, JVP. It indicates right ventricular enlargement. Right ventricular. So what are the evidence of right ventricular enlargement? Epigastric pulsations, LPS, raised JVP. And if the RVH is due to pulmonary hypertension, there will be loud second pulmonary component of the second heart sounds. And what is there in the middle? There is a small muscular RVH. So the muscle part, when the ventricle contracts, the muscle will close. So that will start. Just.
Who can do that? Who can do that?
So that is the ejection systolic murmur. So even if you are getting an ejection systolic murmur, maybe ejection is from the semilunar valves, but it depends on the location of the murmur. We can say it is muscular release. So that is how you identify the different types of severity of the murmur. So this one, apart from the heart sounds and murmur, you are concentrated another part of the murmur, that is the diastolic murmur. What we have already told is about the systolic murmur. When you are having a significant shunt from left ventricle, more blood is flowing to the right ventricle through the VSD, through the pulmonary go to the lungs, oxygenated, come back to the left atrium. From left atrium, more blood is coming. Apart from the superior ventricular blood, inferior ventricular blood coming to the right ventricle goes to the pulmonary. Apart from that, there is a shunt of blood is also coming into the left side. So the left atrium gets enlarged. And when the diastole starts, they be well opened. Because the left atrium is having large body of blood, the first rapid filling, then followed by a slow phase. Even that slow phase, there is more blood is flowing. So what it can produce? Why it is getting delayed? It is in the middle part of the diastole. It is the mid-diastolic murmur. The diastolic phase is first rapid filling, stasis, filling due to atrial contraction. So that stasis phase, there is more blood is flowing into produce a mid-diastolic murmur. So if you are having a pansystolic murmur and a mid-diastolic murmur, it indicates there is significant left production. So you will be saying that is whatever a large VSD, apart from a louder second pulmonary component. So then the question that they will be getting, what is chance of closure? How we are going to predict? See, 80 to 90% of the VSDs will close, small VSDs will close naturally. And 60 to 80% will occur within the first 3 years. So you diagnose a small VSD, you will reassure the parents that within 3 years it can close. Or go to 8 years, 90% can close. That means we did not hurry to see a cardiologist. Just say this is a small VSD will close. Wait. You are on the watch out for any complications only. But very rarely this VSDs, large VSDs are closing spontaneously. There is a chance, but it is less. So that is the natural history. And there are some VSDs, even if it is small, you have to close it. What is that VSD? No, the location, anatomical location of the VSD, that which is unlikely to close. Supracrystal VSD, the problem is there is chance of aortic regurgitation. So even if it is small, that is subpulmonic VSD is associated with the AR. Though we have shown that the area where the semilunar valves are separated, when there is a defect, the valve cusp will prolapse into that defect. And it will close the VSD, but it will result in aortic regurgitation. So subpulmonic VSD, even if it is small, you have to close. And there is an inlet VSD. Classically, you are getting it septum primum, ASD, VSD, inlet VSD, and MR. The combination you are getting in a AV canal defect, atrioventricular septal defect. That inlet VSD is unlikely to close. So these are the VSDs you have to do a surgical correction. Subpulmonic VSD, inlet VSD, or a malarial VSD is what you are getting in a tetralogy or parallel. These are the VSDs you have to close it. So what are we going to do with the VSD? Medical management. It is a part of the pre-physician. You have to give proper nutrition. Give all immunization because the child is not going to get recurrent infected. Whatever available vaccines are available, not only the national recommendation, all the available vaccines you have to give to prevent infection, prevent infective endocarditis, prevent anemia. Anemia will result in high output cardiac failure. So you have to prevent anemia, good nutrition, immunization, all these things are our duty. And if the patient is having cardiac failure, what are the drugs used in cardiac failure treatment? Diuretics, beta blocker, digoxin, AC. That is more important. You know, when you are having a shunt lesion, the muscle is having good power to contract. There is not enough fiber. So those who are having good contractile power, why there is no need of any iron drugs? What is their problem which is making ventricle failure is your volume power. So that is why you are giving diuretics. You make the lung dry by decreasing the volume. So diuretic is the first drug. And why there is AC inhibitor? When less blood is going to the kidney because of the failure. Hypovolemia, cardiac output is less, renal perfusion is less. Then how we are going to correct the blood volume? What mechanism? RAS, renin-angiotensin aldosterone mechanisms. So that will come. There comes the role of spironolactone, AC inhibitors and all these things. So now the cardiac failure treatment goes option is ADD, AC inhibitor, diuretics, digoxin. So digoxin role has come last because the muscle is having good contractile power. Inotrope is not required there. And even if you are giving digoxin, it is a weak inotropes. So nowadays people are not preferring to go with the digoxin. So this you have to remember. Whenever you are presenting a case of ESD, the examiner will be asking, it's a small ESD, what do you do? We know the natural ESD. He will say just observe. Give infected prophylaxis, wait for all the nutrition, immunization, follow, he will know. And if it is a moderate size ESD, when you have to take up for surgery, by 2 to 4 years. By that time, what you will do? All these general measures plus treatment for cardiac failure. So that is, then the patient is here, you can go for surgery around the before school entry. That is 2 to 4 years. If it is still large, the patient will give a medical trial therapy for ADD, then there is no improvement. Taking surgery to the surgery. So a trial of medical therapy for 3 months, the patient is not improving. You will be very large PhD, you have to take for surgery, early surgery. Other patients who are getting response, wait till 2 to 4 years before school entry. Very small defect you can left alone. So this will they will likely to ask. So now what about you? You know you are confident enough to make diagnosis of BSD? You know the symptoms, you know the physical findings, you know the severity, you know the anatomical locations, and what is the treatment, and what are you going to do? You counsel the mother regarding the course of the BSD. Okay? So that is the thing you are likely to get in your examination. So what about the ECG, X-ray? X-ray there will be cardiomyopathy. And why there is the right atrium is also getting enlarged? Because pulmonary arterial hypertension. And what is this bulge along the left border? See the top one is aortic arch. Then main pulmonary artery. What is this one? Who told that? First one who told? Left atrium who told? Yes, tell your name. It is the left atrial appendage. Left atrial appendage. So the left atrium is also getting enlarged. And the ventricle is coming and almost touching the rib. Which ventricle is enlarged? Left ventricle. It is down and out. So left ventricle is enlarged. And the pulmonary blood flow will be. The PDA, almost all these symptoms will be there. Left ventricle is enlarged, left atrium is enlarged, symptoms are almost same. The findings are continuous murmur. And there have been multiple clicks and sounds when you auscultate. It is a classical machinery murmur or train internal murmur. Somebody goes to the train, you can experience the murmur how you are getting. So train internal murmur, the location of the murmur is in the intraclavicular area. Okay, so that is how. Just you look for collapsing pulse and a continuous murmur, you make the diagnosis of PDA. Other things almost similar. And sometimes the PDA may be a life-saving thing. There are conditions where there is right side obstruction or left side obstruction, pulmonary atresia, aortic atresia, all these cases, PDA is life-saving. So this is what I have told, the continuous murmur. What is this? See, this is the first sound, this is the second sound, this is the first sound. This space is the diastolic, this is the systolic. Here there is a small mid-diastolic murmur. What it indicates? Large defect. And there is not much diastolic component, it is PH. And the other one is classical continuous murmur. It crosses over the second sound and there is a mid-diastolic murmur. You may be getting a one mark question in the theory. Draw the auscultatory events. That is why I have drawn this. Most of the students they will just draw one continuous murmur. But if you are writing like this, small one, large one with the PH, we have no choice to give 100% marks. So that is the difference in the large PDA with the severe PH, small PDA, continuous murmur here also, and it is very difficult to identify the mid-diastolic events and all these things. But you have to draw definitely the pan-systolic murmur. So apart from that, left atrial enlargement, what is there in X-ray in a PDA patient is a prominent aortic membrane. Prominent aortic membrane. The topmost part. Left bottom topmost part is the aortic membrane. That will be more prominent in then the question comes, what are the differential diagnoses for a continuous murmur? What are the differential diagnoses for a continuous murmur? Physiologically, what is the murmur? It is a venous murmur, mammary sulfur, and organic murmur, acyanotic and cyanotic. Acyanotic continuous murmur, PDA, AP window, and systemic arteriovenous fistula or coronary arteriovenous fistula. We studied 1 or 2 PDA, continuous murmur, and arteriovenous fistula, either systemic or coronary. That we can remember. AP window, all these things, at least then you are getting a coarctation, anastomosis around the scapula. There is a continuous murmur you can get. What you are studying is a Sussman sign and all these things. Then cyanotic disease, you will get in a tetralogy of Fowler with PDA, or we are doing a BT shunt. That can also produce a continuous murmur. So BT shunt, TAVDC, truncus arteriosus, all these things are the differential diagnosis for continuous murmur. At least you remember physiologically venous one, pink one continuous PDA, RSOV or systemic arteriovenous fistula. In cyanotic disease, tetralogy with PDA or MARCA. Then you have BT shunt unrestricted or TAPVC unrestricted. That can also produce a continuous murmur. So blue and pink. So this synoptic lesion, all these things they are not going to ask. Okay. So that completes the time I can.
30 minutes. 40 minutes.
So
You can catch up with the case.
So we will go with the case discussion. We are going to analyze. There is a symptoms, asymptomatic, and right to left right already we have got. Now we are going to discuss a case regarding the right left. Okay.
And I will be presenting a case of cardiovascular system Bluish discolorization of the palm and fingers from 6 months of age, breathlessness from 1 year of age, poor weight gain from 1 year of age.
Okay. Stop. So bluish discoloration of tongue, fingers, 6 months of age, and breathlessness 1 year of age, and poor weight gain. What is the likely disease? Cyanotic heart disease. Cyanotic heart disease. Are you sure? Is it decreased pulmonary flow? Increased pulmonary flow? But the child is having breathlessness, poor weight gain. We have told when there is increased pulmonary blood flow, recurrent respiratory infection, failure to thrive, and breathlessness. But here, a decreased pulmonary blood flow and breathlessness. Anyway, you are sure that this child is having a cyanotic heart disease. Is it? Why you are telling it is a cyanotic heart disease? Is it why not it is respiratory? Can be respiratory also. Huh? Why it is not respiratory? Child is having breathlessness. No fever. Huh? Is a problem? I am telling it is pneumonia, breathlessness and cyanosis. So, the duration of the illness making some confusion. From 6 months, and now the child is 4 years, and from 6 months onwards, a pneumonia cannot occur. Then it may be a chronic lung disease. Why not? Can be a chronic lung disease. Is it? That we don't know, we have to get the exact history. Is it a central sinus or a peripheral sinus? Central sinus. So now the thing is, if there is central cyanosis, there can be bluish discoloration of tongue and mucous membrane. And the more reddish area becomes bluish. And if it is peripheral cyanosis, there need not be this white, more perfused area cannot be blue. It is the distal part which is poorly perfused getting cyanous. So that is one point. And poor weight gain we don't know. Maybe the child may be having some other disease. But it can be a heart disease as well as a respiratory problem. Okay, then we will hear what is the history of the presenting illness. Okay.
History of presenting illness. Child was apparently normal until 6 months of age, after which his mother noticed bluish discolorization of lips and extremities, which increased during crying, for which the child was taken to the nearby practitioner. He diagnosed as congenital heart disease and referred to higher center, but the parents didn't take him for consultation or follow-up. Cyanosis progressively increased from 2 years of age onwards, and mother noticed frequent squatting posture of the child while playing.
Okay, this child is having breath holding spell. Is it? Is it? Huh? Whenever the child cries, there is bluish discoloration. Is it cyanotic spell or breath holding spell? There is no spell. When crying only is having bluish discoloration. It increases while crying. That will be there in cyanotic spell also. So how can you differentiate a breath holding spell from a cyanotic spell? Paroxysmal crying can also occur. Deepening of cyanosis will come because there is no sinus while crying, there is cyanosis. Apnea, that can occur both ways. Huh? There is a behavioral change. That also occurs in both 6 months onwards to 2 years. On stimulation, disappear, and crying continue. So what is happening in a breath holding spell is they will arrest you. They are not taking the breath. They will hold the breath in inspiration. You will cry. No sound. First they will cry. Then become blue. Once the child take a deep breath, cyanosis will disappear. But in cyanotic spell, what will happen? What are the triads of cyanotic spell? What are the triads of cyanotic spell? Cyanotic spell triad. Symptom. Hyperpenia, deepening of cyanosis. Hyperpenia, deepening of cyanosis. What is the other thing? Irritability. Irritability, hyperpenia, deepening of cyanosis. Here there is no stoppage. Deep and rapid respiration. That is hyperpenia. And just very small cyanosis goes on, the cyanosis will get deepened. Child may be having mild cyanosis, but when crying episodes comes, it becomes more deeper. And the respiration becomes deep and rapid. And what will be the heart rate? Cyanotic spell. Heart rate will be increased. Respiratory rate become deep and rapid. Cyanosis become more, and the child become more irritable. So that is cyanotic spell. In breath holding spell, the child is absolutely alright. After crying, hold the breath. And then what will happen if there is hypoxia? What happens to the heart rate? Bradycardia. The other one is tachycardia. So that is how you differentiate the breath holding spell from cyanotic spell. So you know the triads: irritability, deepening of cyanosis, hyperpenia. Tachycardia will be there. The other one is bradycardia. Okay. Yes. Continue.
Mother also noticed dyspnea of the child since 1 year of age, as he gets tired easily while playing when compared to children of his age group. He becomes breathless even on running for a short distance, so a modified Ross grade 2 classification of dyspnea. Due to breathlessness, he used to limit his physical activities.
Okay. So he is having what type of dyspnea? Exertional dyspnea. He is having exertional dyspnea. So the functional class 2. Everybody knows what is Ross classification? Anybody can tell Ross classification full? Tell the Ross classification.
So class 1 asymptomatic, class 2 mild dyspnea or diaphoresis on feeding in infants, dyspnea on exertion in older children, class 3 marked dyspnea and diaphoresis of feeding in young children, prolonged feeding with growth failure, marked dyspnea on exertion on older children, class 4 symptoms of tachycardia, grunting, cyanosis, diaphoresis even at rest.
Okay. So it is very easy to remember. Asymptomatic, class 1. Not much symptom. Always symptomatic, even at rest. Class 1. Class 3, what is the classical finding? All symptoms are exaggerated and there will be failure to thrive. Any symptomatic child with failure to thrive, it is class 3. But there is no failure to thrive, all the symptoms are there. Why there is diaphoresis, tachycardia? Why autonomic? See, when your heart is failing to provide enough oxygen, you increase the rate of the heart. What is the mechanism that can produce increased heart rate? Is your sympathetic system. So your adrenergic things are stimulated, heart rate is increasing. Not only the heart rate, it can produce septic also. Can produce tachycardia, can produce tachypnea, can produce fatigue. So all these symptoms are there for an infant while feeding. That is the exercise that the infant is doing. While feeding, he gets tachypnea, tachycardia and fatigue. But he continues to feed. That is class 1. But when all the symptoms are pronounced, he is forced to take a rest. He cannot continue to suck. He will take a rest. Again he will suck. While sucking, he will get some relief of symptom while resting. So what will happen to the total duration of feeding? It is increased. There is a sucking cycle, rest cycle, again suck. And what we call suck rest cycle or feeding, crying, resting cycle. Why the child is crying? Because there is hypoxia. Because child is hungry. The baby's tummy is not full. He started crying. So if you cry more, what will happen? You spend more oxygen. You spend more calories. You demand more oxygen, but the heart is not filing enough to give oxygen. So there is failure to thrive. So that is why the class 3 symptoms there is failure. Failure to thrive and even without any exercise they are getting, that is the class 1. So that is the equivalent, NYH equivalent in pediatrics. And previously the Rose classification was there for only infants. Now it is modified up to the age of 6 years. So that is called modified Rose classification. The spelling of Rose is not R-O-S-E, it is R-O-S-S. Okay. Then.
History of inadequate median in spite of good appetite and feeding. No history of palpitation, syncope or seizures. No history of recurrent respiratory tract infection. No history of head sweating or suck-rest-suck cycle in infancy. No history of difficulty in taking feeds. No history of perineal rocking.
So, why there is inadequate weight gain? All these things are manifestations of increased pulmonary. What we are telling a child with decreased pulmonary. So probably even we have some other illness, we don't know. Is it? When the history further here will know. Then what is there? No history of palpitation syncope. This is an outflow obstruction, decreased outflow. That is also not there. History of recurrent infection again increased pulmonary blood flow. We are not expecting. There is no need to tell that one. But any cyanotic heart disease, if it is a cough, why there is increased pulmonary, why there is increased respiratory tract infection? Any chance that there is increased respiratory infection? A cyanotic heart disease, like cough, is having increased respiratory infection. This is a question. Those who want distinction, they can tell. Why? It is a decreased pulmonary blood flow. And a cough, diagnosis is cough, but he is having recurrent infections. Anemia is there. Anybody? Now PGs can answer. PGs.
Were they listening?
Question. The technology of fellow, there is increased respiratory infection, not increasing infection.
In infants.
So what is the syndrome associated with this type of decreased pulmonary cough like thing? Syndrome. You catch that point. Syndrome. Catch that. Yes. What is it? Catch the Diaton. What is there? Thymic hypoplasia. They can have immunodeficiency. They can have hypocalcemia. So there is chance. So sometimes there can be, and no history of accepting success cycle we are not expecting because this is a decreased pulmonary.
And initially, sometimes the VSD may be the dominant. We have seen
So,
cases like that.
What madam is telling, increased pulmonary blood flow like condition initially, and there is no cyanosis. What is that called? Pink fab. Pink fab. Who told that? Your name? So pink fab. Pink fab, the pulmonary stenosis is not that severe. So pulmonary blood flow is there and it behaves like a VSD. So there is increased pulmonary blood flow, VSD, recurrent infection failure to thrive can be there. So that is the pink fab. PND orthopedic naturally increased pulmonary we are not expecting. All negative history which again supports the decreased pulmonary blood flow condition. Okay, then.
As a part of evaluation for failure to thrive, an USG was taken and the child was diagnosed to have bilateral hydronephrosis and vesicoureteric reflex of grade 4 at 1 year of age, and corrective surgery, pyeloplasty and ureteric reimplantation was done 5 days back.
So now you got another thing. This child is another congenital problem. and then now you can explain why there is failure. Is it? There is a chronic renal problem. Basically, like cytonephrosis and all these things. So that is there. Now our question is, how can you link this disorder with your primary heart disease? Renal and heart. Any other condition where you are having both together? Yes, PDs. Very good. What is your name? Satyaprabha. Bacterial anomalies, renal, vertebral, anal, all these things they can have congenital heart disease association. So that is there. Okay. Then.
Past history, no history of vaccine preventable diseases, no history
So
of
there is nothing relevant in the past history. Okay. Then.
antenatal history, third pregnancy conceived at 30 years of age, regular ANC, iron and folic acid tablets were taken, adequate
So
blood pressure.
everybody knows how much iron and folic acid? How many tablets? 180. Good. Okay. Then. All these things are nothing relevant. Then.
Natal history, full term normal vaginal delivery in the hospital, cried immediately after birth, no history of birth
So it's a
asphyxia.
normal baby, birth weight is 2.7 AGA baby. Okay, then.
But
Neonatal history,
neonatal history, no history of
there is not
respiratory
much
disease.
jaundice, constipation. What are the causes of delayed onset of memory? Cystic fibrosis, evaporate anus, Hirschsprung disease. Last one. Hypothyroidism. You should never forget hypothyroidism. Then. Okay.
Developmental history,
So what is the need for taking developmental history in a heart disease patient? What do you expect? What do you expect in a developmental history in a heart disease patient? Our main batters are out. Then syndromic babies, there can be global delay, Down syndrome, global delay. And there are some patients who are having increased pulmonary pressure, lateral respiratory infection, they become very fragile, and there can be gross mobility. When you take a cyanotic heart disease, there can be total growth of the standard, wasting, everything can be there. So that is the importance of thing. When syndromic comes, there can be development. Okay. Then here everything is normal. Then
Feeding history, breastfeeding was started immediately after birth, exclusively breastfed till 6 months of age, and breastfeeding was continued till 1.5 years
so
old.
there is nothing contributory in that one. Diet during illness, any diet specially recommended in a heart disease patient, what you will ask? Diet in a heart disease patient. Fluid restriction, salt restriction, high fat, high protein. Anyway, you have to give iron containing food items. Micronutrient deficiency you have to avoid. And you have to give a fluid restriction when there is a edema. Okay, then family, feeding, then
Third child, third degree consanguineous.
so there is consanguinity, we have told what is the importance. Then
Immunization history, immunized as per national immunization schedule till 1.5 years of age. No other recommended vaccines taken, no adverse reaction following.
so he is immunized for the age. What else you will ask? Apart from the national schedule, whatever available vaccine you will give, what is the importance of the we have told. Now, which vaccine can prevent a heart disease? Who told? Yes, mumps, or rubella case, you can give a vaccine that can prevent a PDA or a rubella syndrome. Okay, then. Yes. Continue.
General examination, the child was active, playful and alert. Central cyanosis present with bluish tongue and fingers. grade 2 pan-digital clubbing present, polycythemia present, no pedal edema or general lymphadenopathy, no facial dysmorphism.
So there clearly says that it is not a syndromic period. And what is the common syndrome? What we have told is the Dye-George syndrome. And there are some microdeletion syndromes. Microdeletion syndrome, that is the Dye-George. And there can be Down syndrome, there can be Patau syndrome, and trisomy 18, 13, all these things can are associated with the pathology of hair. Then clubbing is characteristically seen only in a central cyanosis, not in a peripheral cyanosis. Okay. And how you can diagnose grade 2 clubbing? Okay, what is that sign? Shamrose sign. Shamrose sign. So you can look for the clubbing. Okay, then.
Vitals, pulse was 110 beats per minute, regular, normal volume, no special character, no radiofemoral delay. All peripheral pulses were felt equally on both sides. BP 96 per 70 HD in upper limb and 106-70 millimeters of mercury in lower limb. Respiratory rate is 30 breaths per minute. Temperature is 99 degree Fahrenheit. Capillary refill time is less than.
So after what saturation will you get as clinically evident cyanosis? Clinically evident cyanosis, what saturation? 85. So this time is 76. Okay, then go. And growth parameters, there is stunting and wasting is there, microcephaly is there. Okay, then.
Head to toe examination, head and neck, anterior fontanel and posterior fontanel closed, no facial dysmorphism, no cataract, conjunctival suffusion present, nose is normal, ear is normal, no deafness, oral cavity, cyanosis in tongue, dental hygiene is good, no webbing.
Why you are particular of dental hygiene? Which are the high risk group for infected endocarditis? High risk group for infected endocarditis. All CCHDs are high risk, or whether operated or non-operated. All ACHD with the artificial membrane, or you use throat patch and other thing, or prosthetic bag. All these things are high risk for infected endocarditis. If this child is presenting with fever and other features of cardiac failure, we'll think of infected endocarditis. Then.
Pectus excavatum present, no Harrison sulcus, no limb deformity, males clubbing is present, cyanosis is present, no chylomachia, no umbilical or inguinal hernia.
It's very difficult to have a chylomachia and clubbing together. Okay, then.
Hernial orifice is normal, external genitalia is normal, skin is normal, no neural.
So everything abnormal there to foot? Okay, then. So all this what we have to look is the dysmorphism is there is evidence of all these things, and apart from the clubbing and then.
Cardiovascular system examination, inspection, apex get seen in the fourth intercostal space, just medial to the mid-clavicular line.
Is there any cardiomegaly? At 2 years, where is the apex? Fourth intercostal space? In the mid-clavicular line? Right or left? So there can be disability. It is the fourth intercostal space left along the mid-clavicular at 2 years. At what age it become? Fifth intercostal space upon its medial to mid-clavicular line? 5 years. After 4 years. After 4 years. So 2 years, fourth intercostal space mid-clavicular. More than 4 years, it is happening in your left intercostal space. That adult. In between, that is the in between these two spaces. So that is there is no cardiomegaly. Are we expecting cardiomegaly in trough? No. Okay.
The JVP is not elevated, no visible pulsation is seen, no dilated veins, scars or sinus is seen.
Okay, then.
Palpation, apex being felt in the fourth intercostal space, just medial to the mid-clavicular line, tapping in nature, thrill is palpable in second and the third intercostal intercostal space along the left sternal border. P2 is not palpable. Carotid pulsation is felt and or normal.
Okay, there is a palpable thrill at the second space. What is due to? Pulmonary stenosis. Pulmonary stenosis. If the pulmonary stenosis is severe, will there be any murmur? No. So what it tells? It is not that severe. That is why the child is having not that much cyanosis. So it is progressively the pulmonary stenosis is increasing. Then cyanosis is also progressively increasing. So there is thrill and carotid pulsation. P2 is not palpable. P2 cannot be palpable. The pulmonary component cannot be palpable. The aorta will become more empty. It is loud. That is what happening in petrology. The pulmonary component will be soft. Then wait. Percussion hardly we are doing in pediatrics or in cardiology examination. We say combine. Percussion and percussion together we can do. And there is no cardiomegaly. Auscultation, S1 normally heard. Then
S1 is normally heard and S2 single loud, no additional click heard, and ejection systolic murmur of grade 4/6 is heard with the diaphragm of the stethoscope with patient in the supine position.
so why there is single S2? Why there is single S2? The pulmonary stenosis is making the P2 component soft or it is absent. And the A2 is become loud. And the aorta is coming towards the right ventricular side because the upper part of the septum is deviated towards the right ventricular side. Right ventricle forms the precoid. So the aorta comes more anterior. So you can really hear loud second heart sound with aortic valve closure. So that is the single loud A2. That is the classical tetralogy of that. Then.
Respiratory
So other sister anything abnormal? No. Okay, what is your final diagnosis? Why you want to examine the central nervous system? Why you want to examine the central nervous system in this case? Complications. Complications like brain abscess, dural venous sinus thrombosis. All these things can bring about a seizure and clinical management, headache, vomiting, altered sensory overload. So that is why we are examining. So your diagnosis is congenital cyanotic heart disease or cyanotic heart disease? Congenital cyanotic heart disease, decreased pulmonary blood flow, tetralogy of Fallot, no complication. That's how you have to write the diagnosis. Congenital cyanotic heart disease, decreased pulmonary blood flow, tetralogy of Fallot, no complication. And the child is having other complications like VU or and there is basic swelling also. So that is your final diagnosis. What are you going to do?
5 minutes.
5 minutes. Okay. What are you going to do? No, you will take an X-ray, echocardiography, ECG, blood count, and all these things. Find out PCB. PCB is very important. Hemoglobin is also very important because when your body is trying to make more oxygen, so by increasing the RBC. So more RBC means more polycythemia. More polycythemia means there is hyperviscosity. If there is hyperviscosity, there is thrombosis. Where you get more thrombosis? Inside the sluggish circulation. Is it in the artery or the vein? It is the vein. So you will get a venous sinus thrombosis. And when you are having more venous thrombosis, more platelets are consumed. Then what will be happening? Thrombocytopenia. Then what will happen? Bleeding. Then what will happen? Anemia. So there is more chance of anemia because increased production, increased utilization. So there is more requirement of iron. That is why you are giving iron for the CCHD patients. And what else you want to get? Why the brain abscess and the thrombosis is more common less than 2 years? Less than 2 years it is more common. Their blood volume, if it is a very proportional small loss of blood volume or diarrhea, vomiting, they can hemoconservation can occur as earlier than adult. So always prevent dehydration. That is again prone for a thrombosis. So dehydration prevention or give ORS, that will maintain this. Give iron, give infected product, treat all the infections. These are the one we can do as a physician. And treat the cyanotic spell. So we will tell the cyanotic spell treatment. So first you make the child calm. Make the child calm. Give morphine. Give oxygen. Why there is a mixing? Then what is the point in giving oxygen? It is already right to left shunt. Why you want to give oxygen? The oxygen can be carried through the dissolved concentration in the plasma. Dissolved oxygen concentration depends on the partial pressure of oxygen. You give high pressure oxygen, it can increase the dissolved oxygen concentration. So you can give oxygen, make the chest knee abdomen or knee chest position, or the child is kept in the squatting position. All these things will prevent more desaturated blood is not coming to the right ventricle. So, and when you are having a femoral artery thinking, what will happen? The systemic arterial pressure will increase. So, aortic root pressure will be increased. Then what will happen? It reverses the right to left shunt. So, that is the mechanism when you are using the squatting or a knee elbow position. And moreover, when you press the knee over the abdomen, what will happen? It presses the splanchnic veins. And that blood will go to the right ventricle. Splanchnic veins are containing more oxygen than your lower limb veins. So once you kill that one, the femoral vein is occluded and your splanchnic blood is going to the right ventricle. So more oxygenated blood. That is why you are using that position. So that is, then you sedate the baby with a morphine. It can reduce the heart rate, can reduce the respiratory drive. When you go on deep and rapid respiration, you are spending more effort, more oxygen demand. You become more hypoxic. So you will suppress that one by giving a sedation. And heart rate will be coming down. And you give oxygen. Then once the patient is not having that problem, then increase the peripheral vascular resistance by giving phenylephrine or noradrenaline. That can increase the aortic pressure and reverse the right to left shunt. So once all these things are failing, what you can do is then correct the hyperpnea. Because of the decreased oxygen to the tissues can produce lactic acidosis. So acidosis can produce Kussmaul's breathing, deep and rapid respiration. All these hydration and other measures did not control the hyperpnea. Give bicarbonate correction. Acidosis. Still the patient is failing, sedate the patient. And you can take the patient for temporary procedures, like you stent the PDA or put a stent in the RVOT, right ventricular outflow tract, so that you can take the child for a corrective surgery. What is the age for corrective surgery? 3 to 6 months is very critical condition, otherwise we will call it as early infant repair. That is after 6 months or before 1 year. 6 to 9 months, people are not going for VT shunt and other thing. They will straight away go for an intracardiac repair. So that is all about tetralogy of Fallot. The classical finding in tetralogy of Fallot, child will have a central cyanosis, the pulse will be unremarkable, and the precordium will be silent, and no cardiomegaly. And the classical finding you are getting is a silent precordium and single loud S2. Single loud S2. That is a classical finding. The pulmonary stenosis is mild, there can be a whenever you are getting no murmur, that means critical pulmonary stenosis. But always you have to auscultate for a collateral murmur. Where you look for the collateral murmur? Intraclavicular area, right side. It can be a PDA. Interscapular area, back, or in the axilla. This is called the MACAS, major aortopulmonary collapse. So what will be there in MACA? There will be a continuous murmur. But when you compare with the PDA, it's of a low tone. Like continue. That is the one we have to specifically look. Okay. Thank you. So therefore, nice effort to prepare this in 3 times. We have